Welcome, ladies and gentlemen. My name is Erica. I'm chairing the life surgery today with the surgeon,
Switching stick.
Prof.Bancha. Hello. Okay. So while we connect with the hospital in process, I would like to introduce our surgeon. Our surgeon today performing surgery is Prof.Bancha Chernchujit from Thailand. He's the attending surgeon in
You're going live
University.
now?
Yeah, we are going live now. Can you hear me, Professor Bancha?
Hi.
Hi, this is
I
Erica.
hear you very well, Eliga.
Yes.
Okay.
You look very good.
Thank you so much. Can you see well?
Yeah, hello everybody. So today Professor Bancha is going to show us a case about a 67 years old female with high-grade partial bursal side tear with a very big keel acromion spur, I think. So he's in a B-chair position with so many lovely assistants.
Yes.
Like a show.
Hi. So first we introduce our team. Dr. Alisda, the host from Siloam Hospital. Thank you, the hospital, for the hospitality. And we have Dr. Sun, my fellows here. Sun? Yeah, Dr. Sun, Dr. Sek Sun. And also Smith Nephew team. And yeah, Ashley, yeah. Okay. So Smith Nephew team from Thailand and also the assistant nurse from Siloam Hospital. Okay, thank you, all the team. So this patient, Arisna, she's 67 years old, right? She had the chronic shoulder pain and failed conservative treatment. So we found that she has a bicep tenderness, right, Arisna? And also the job test positive, Hawkins side positive. Yes. So she has very big spur. Now we put the camera in the joint. You can see well, right, Eliga?
Yes, it's crystal clear.
Yeah.
Go ahead.
Crystal clear. Very nice. This is a 4K camera from the Smith Nephew. So when we get in, you see that you have a very bad bicep. You see the biceps is torn, right? And that's you see the torn extending from the bicep. That is the supraspinatus attachment, right? When you look at this is a bicep pulley, and you see at the subscap that a small partial subscapularis tear here, right? Upper part, okay? Patient have a little stiff, but after an examination in the theater, her range of motion is good, Arisna. I think that's because of her pain, yeah. Right. So our plan today is to do the biceps tenotomy because of her age. Yes. You agree? And then we do the decompressions and rotator cuff repair, double row techniques. Okay?
Sounds like a good plan. Sounds like a good plan.
Yeah. So how about your trend in Indonesia? You do biceps tenotomy or tenodesis in your practice?
I think it really depends on the source of pain. Biceps, it's not really the only cause of a pain. If physical examination really support the a pain source and imaging say so, I think a procedure to the biceps can be performed after we confirm with arthroscopic finding. So because a tenotomy, it seems very fast and straightforward procedure, but if let's say a tenotomy was performed, the chance of having a biceps tenderness, your seat belt surgery in the future, for example, to reroute if you need a rotator cuff surgery is gone. So you actually burn the bridge. So I would like to say it's really tailored. It's not a trend, it's a clinical decision.
Okay, thank you, Eliga. So first we make a superior portal. This portal is just in front of the AC joint. Okay, you can see from outside. So I forgot to mention about the portal. Can you show the outside view again? So this is acromion here, a marking pen I'm showing you. So we have the posterior portal here. Yeah, this is from the corner. We go about 2.5 and 2.5 down. This is my posterior portal. And from here, we divide the acromion into 3 parts. So 1 centimeter down, this is my viewing portal. And about 3 centimeters down here, this is my lateral working portal, okay? And another portal is just in front of the AC joint, okay? So I use this portal for my bicep surgery, for my ankle placement, and also for the release, okay? So
I
half height.
agree with you, yeah. A portal placement is very important. It means that 50% of the surgery is actually almost done if you have the portal
Right.
placed correctly. Because arthroscopic surgery is a keyhole surgery, so portal is very important.
Yes, right.
So, will you use cannula at the front?
Oh no, at the beginning we did not use cannula. We starting with the bicep tenotomy first.
Right.
You see the bicep is quite big. Okay, I start to yellow piece, cut my bicep at the bicep root. Okay, close to the bicep insertion.
Yeah. So this is the biceps anchor to the slab. He's
That's
doing
right.
a release now with the radio frequency. I think you're using a werewolf by Smith and Nephew.
That's right.
Yeah, okay.
That is a very good
if we
IF.
can
Thank
listen
you,
to the
Elika.
sound, yeah, it's very nice.
Advertisement. Thank you.
Okay.
Nice. So we have a nice support from the Smith and Nephew.
Yeah.
Hello. Okay.
If we have any question from the floor, please feel
Yeah,
free
you
to
can.
raise
You
your
can.
hand.
We are very happy if you have the question. You can interrupt me anytime.
Yes. No.
Yeah. Yeah. So now you see MJSL. I prefer to cut it yellow.
Yes.
Okay. Because after the surgery, we don't want to have stiffness. So
Correct.
for me, I prefer to do the release to prevent the stiffness after surgery. I release MJSL and some part of the IJSL like this, right? The most of the list of stiffness will be less, yeah, from our study. Okay, so that is I release my MJSL, IJSL, okay? Especially if you have subscap repair, you should release this. Otherwise, if you repair your MJSL, IJSL to the subscap, there'll be stiffness after the surgery, okay? And this is my rotator interval, right? If the patient has stiffness, I prefer to release this rotator interval. The trick is that my assistant push the shoulder down like that, and then I can slowly release that until I see the coracoid process, okay?
Okay. So pushing the humeral shaft.
Yeah, pushing the
back is
humeral to the
really
back, you
helping.
can have space. You see that?
Helping.
After you release that, you can see the coracoid process in the back. And that is the conjoint tendon, you see? Conjoint tendon and the coracoid process in the back, okay? Okay, so that is my interval release.
Yep.
Okay, but Dr. Chuhan, he don't like to do this. Yeah, he always tell me that he don't like to release the interval.
Okay. So
But
you are using a assistant arm, not an assist arm.
I use the resident arm, fellow arm.
Assistant arm. Okay.
No assistant arm, yeah.
I think it's the best.
Otherwise, they will be sleepy, you know. We need to find some job for them.
Okay.
Elika.
Makes sense.
Yes. Okay, you can see well. That is the conjoint tendon, right? And coracoid process. Okay. Okay, from here, I think I finish. And you see my subscap, yellow?
Yes. Upper part.
I will try to combine, I will call sharing anchor. So I will add it part of the subscap to the supraspinatus. So we don't need to pay, yeah, I know the anchor in Indonesia is expensive, right?
Yeah.
So we can sharing the anchor supraspinatus to your subscapularis.
Yes.
Okay? I show you how to do that, okay?
All right.
That's I finished my
you
job.
will be using, if I
Hello.
may know.
Okay, half high, please. And then I make some raw surface.
Oh, okay.
Ever?
So as we can see in the arthroscopic view, we have an upper part partial tear of the subscap.
That's
which
right.
is a very important stabilizer at the front to balance the cuff.
Right, but that's
For the subscap tear, may I ask if, let's say the tear is extending to the distal side for a full thickness tear, will you use a 70-degree scope to proceed, or just a 30-degree scope is enough?
So if the tear extending down, I prefer to use 70-degree scope. Right, Elika, so we can see better. We can see the footprint better, okay? You see that it's torn not too bad, I think?
Yes.
Yeah, you can leave it or you can repair it, right?
Yeah. So what is the trend
Yes,
in
no
the
symptom,
room? Will
actually.
you leave it or repair it? Like,
It
I
depends on
think
the
he's going to
symptom and
repair
also
today.
extent of the tear,
Yeah.
okay?
Yeah. To
So
give
now,
us some show. Yeah.
yeah. So now you, I think we have finished our job in the joint, okay? And
Right.
then looking at this, we have some extending of the tear, okay?
Right.
Also some lamination, okay? So now I will switch my scope to the subacromial space, okay?
Yes.
Okay, so we switch the scope to the subacromial space, Bancha, please. So we're going in the subacromial space, okay? So first thing is that we will, oh, sorry. Wait,
Okay, this is the subacromial joint. Usually there is a lot of bursa in it, so perhaps debridement is needed to see very clearly. Some
Yeah, right.
attraction to the floor is helping to visualize the subacromial joint, which is like a forest. Don't worry about it, just need some.
That's right. Aliga. So the subacromial space is a potential space. Many times you get lost, yeah, especially the beginner, right? So once we get in, first thing is that you need to find your CA ligament. You see that? That is the CA ligament, right?
Can we have the
So
scope view, please?
here you see the CA ligament have some abrasion, right? From Alisna show me the pre-op X-ray, we can see the spur, okay?
Yeah,
And you
it's
see that the spur is underneath this CA ligament, okay? Yellow.
all
So
right.
the way to do that is I will slowly release my CA ligament, right, from the insertion. Not cut it, but just release it like this,
The
yeah?
scale ligament is part of the superior stabilizer of the shoulder
That's
blade.
right,
So
Eliga, but
peel
it's
PH.
a static stabilizers of the shoulder.
Yeah.
So the ways to do that is that I try to preserve the lateral part of the CA ligament, right?
Yeah.
And
Yeah.
also
Yeah.
I just save and slowly detach this. You see that?
Yes.
Then I step this lateral part of the CA ligament.
Yes.
Yeah, you can see we identify the lateral border, anterior border. That is lateral border.
Yes.
That anterior border slowly go this way, right? Slowly release that. Not cut it, but just release it from the bone. Yeah. You see that the spur is quite big on these patients.
Yes, it was really evident in the X-ray. I'm so
Yeah,
unfortunately
right,
not show
right.
the X-ray.
And you can see that that's the boundary, right?
Yes.
If you look at the shape of this acromion, is bad, right? It look like a hook acromion.
Yeah.
That is the base of the spur, okay?
Yes.
So some surgeons don't believe in that, but I think from the evidence, we found that the patient that have the pathologic spur like this, we should take it out. Otherwise, you will have retaliate, or the clinical outcome will not be good, right?
For a normal
If
spur.
patient have no spur, I will not decompress. But you see that? This is obvious, right? Can you see well?
Yes, it is crystal clear.
Yeah.
Some surgeons
Oh,
advocate a lateral acromioplasty a couple of years ago. I think there's a study just to
yeah.
decrease CSA. So I
Okay.
think just acromioplasty is not a sin. I think it really depends on how we will proceed with that case today. It
Okay.
perhaps can add to protection to your cuff. So whenever the patient do overhead activities, it will not grate or let's say put your cuff in danger. Or if you are doing a subacromial balloon spacer, I think it's somehow needed. Yeah. So now he is doing the acromioplasty with the burr. So he start with the anterior edge and try not to make a steep bone deformity to the acromion. Okay.
Right. So Erika, the landmark is here, okay?
Yeah.
I can show you this is the base of the coracoid, okay? And if you expose to the AC joint, it should be in the same level. Can you hold
Yeah.
this? I
Yeah,
turn my camera a little bit. Can you see the AC joint? Is there, okay?
Yeah, this
It's
is a
the AC
great tip,
joint,
so we
okay?
can have a flat
Yeah, can you
acromioplasty.
see? We're
Yes,
pressing this
move.
AC joint. It should be in the same level of the interior part of the AC joint. So for me, I will draw this line from AC joint, okay, to this landmark and draw the line. Yeah, so we will not over decompressions.
Yes.
Okay, this line. You hold that for me.
Because bad surgery is an unfinished surgery, not the other one. So now
Okay.
we are still doing acromioplasty.
Yes. And the trick is that you should cut it from inferior
Yes.
to superior, not cutting from superior because the bone spur will dropping down by the CA ligament and you cannot take it out, right? So identify this landmark and then you can decompress, make it flat, and Elika told us that we should a little decompress the lateral side. We call lateral bevel like this, yeah. So that's the way we do the lateral decompression. Very gentle because in the front there's a vessels. If you are too aggressive, you can create the bleeding because in front of the spur, there will be some vessel at the anterior deltoid, okay, Coracoacromial branch of the axillary nerve.
A few looks very good. Do you use anything in the fluid or just a pressure?
Yeah.
How
pressure,
much
right?
is the pressure now?
Pressure only 30.
Oh, okay.
Yeah, because we have good anesthesiologists, you know.
Yeah, yeah.
They control the pressure very well,
Yeah.
right? So I think that's important. Our Anas. Hi, Anas. Thank you so much. IF, Dr. Henry. IF, please, blue, yellow. Okay. After that, you need to check again. Yeah. Yellow. There's a little spur here. Yeah. Green a little.
Can I ask a question, Bancha?
Oh, yes.
I'm
Okay. So always have a question now.
Let's talk about you.
Hi, it's wonderful
You
surgery.
don't agree with me, like I decompressed your interval.
So I'm really
Okay.
agree on your dimensions about the distal clavicle. So we'd better have to our indication of the distal clavicle resection or the co-planning. Sometimes distal clavicle is protruded to the subacromial space with some
Honey, can you speak louder?
really?
Yes,
Speak
please.
louder. So I think that you can hear me?
Yes, very well.
Okay, so distal clavicle resection, we need some kind of indication. Sometimes it is protruded to subacromial space. So I cut the distal clavicle, the co-planing of the distal clavicle to make it flat.
Yes.
Otherwise, distal clavicle protrusion is related to subscap tear or delaminate tear because medial impingement can happen by the AC joint spur or distal clavicle protrusion. So I agree with you that if the clavicle is protruded subacromial space, we'd better to rim down and cut down to make it flat.
Yeah, I totally agree with you, right? Because distal clavicle also the cause of the medial impingement. Thank you, Chuhani. But the patient have no problem with the AC joint, right? From MI also we have no spur and no AC joint pain, no AC joint impingement. Okay, thank you, Chuhani. So looking at this, I always switch my camera from the posterior to lateral. You can see that this spur is not, it still have some protrusion, right? Like Chuhani said, we should have the co-planing, right? Make it flat, right? So from here, you can see there's still some angulation, okay? If you do the Hawkins side, can you show me Hawkins? Yeah. So if you turn internal rotation, Yeah, you see that you still have some touching, yeah, on the top, right? Here, you see?
Yes.
Very close. Can you see well? So I need to clean a little, yeah? So drop the arm down. I need to make it co-planing, like Professor Shukani recommendation.
So Professor Bancha is now doing acromioplasty with two techniques, anterior block resection and a cutting block, just to confirm from each portal whether we are doing a complete acromioplasty or not. So
yeah, now it's...
Yeah, so now after the acromioplasty, we will have a very nice acromiohumeral distance. Okay.
Yes.
Okay.
Oh, forward. So when you do fine tune, I go to reverse. Yeah, here, reverse cut, you will not do over resection, okay?
Okay.
So make sure that you have flat acromion, this part. Sometimes if the spur projecting down from AC joint, you also need to clean it, right? But this patient, the AC joint is fine. So this is a reverse cut, okay? So you can have the flat acromion from the back to the front.
For those who are just starting arthroscopy, in the safer blade, we have a forward and reverse cut less. So if you are afraid that you are going to cut more, usually for the elderly, acromion is very soft, you can actually start with the reverse one.
Yeah. Thank you, Elika. That's true. I totally agree with you. Because I saw some young surgeons, they are too aggressive.
Yeah.
They make the big holes in the acromion. Yeah.
That's why they are young. Okay.
Yeah, they are strong and powerful. Okay, now I think I've finished the acromion work, right? Now going to the rotator cuff.
Yes.
So first, I'm showing you that this is anatomy, right? After we cleaning, yeah, Sheva. I will change my camera to the superior portal. Switching stick, please. So we make a step incision here on the top, right?
Yes.
And then I put this is like bird eye view. You see, it's coming from the top.
Yes.
So from this view, you can see very well.
Yeah.
Okay. So switch your camera.
I have the same style. I have to see my acromion and face, my rotator cuff and face. So he's switching the working portal to the lateral portal. In order to do a rotator cuff surgery, it's like a meniscus surgery. You have to have a very high portal to perform the surgery. But in order to do the acromioplasty, you have to have a very low working portal to cut it easily. So just take your time, measure your portal.
Thank you so much.
Do whatever portal you would like. Yeah.
You're removing some bursal tissues here.
Yep.
Okay. So the bursal tissue is everywhere, like you say, Eliga. So we need to clean the bursal tissues from the top, from the front. Then you can see the conjoint tendon, right?
Yes.
There, conjoint tendons.
Repair what we cannot see. So the bursectomy is needed in subacromial surgery because.
And we push the humerus to the back, right? RF piece.
Yes.
Then you can see the coracoid process, right?
Correct. Yeah.
Okay, here. Yeah, that is the base of coracoid, yellow.
Yes.
If the patient have very stiff, the very retracted massive rotator cuff, I prefer to release these structures, the coracohumeral ligament here from the coracoid process, right? I will free my supraspinatus here. That is a coracohumeral ligament. You can see that?
Yes.
In massive rotator cuff tear, this structure limit the rotator cuff mobilities.
Yes.
So that is a coracoid process. You can see the whole base of coracoid.
Very beautiful, yeah.
Yeah. Here, that is my anterior part of the cuff, right? So after you release this, the cuff mobilities would be better, right?
Yes.
And I'm showing you this is a conjoint tendon, right?
Yeah. So there is an old, always appear in the textbook, do not go medial to the coracoid
Yeah, we should not. I show you here, this is a CA ligament. You see, attaching from here, stop. Yeah, this is the CA ligament, right?
Yeah.
Going to the base of, to the acromion, that is my coracoid. If you go to the anterior part, okay, here you can see that is the pec minor. You see that? Pec minor. So, but you should not go to this area. This area is very risky. You see that the vessels and also the nerve is there, okay? So do not go beyond that, okay? Okay. Yellow.
Excellent view, yeah.
Yes, so now we're looking at this. Next step is that we will need to
footprint of the...
take down the rotator cuff.
Yeah.
Okay,
we have to know the shape of the rotator cuff first in order to understand how to repair it. So most of the surgeon, maybe a younger one, think that the rotator cuff insertion is straight, but eventually from the Japanese study, I think it's very nice paper by Dr. Sugaya.
Yeah.
The rotator cuff supraspinatus actually is from behind to the front. It's like a curve. The footprint is not that much. In fact, infraspinatus footprint is bigger than the supraspinatus. So if you can actually identify and understand the tear pattern, it's not very hard to repair it. Yeah.
That's right. That's very important. We call the rotator cuff mapping, right? So if you have a good mapping, you can design where is the cuff configurations. Many times the massive cuff is like the L shape or reverse L shape.
Agree.
So if you can find the apex and you reduce the apex, the cuff will be easily reduced. Okay.
Reduce. It's just like an oral IF.
That's right, Alika. That is very important point. Before you start it, you should plan, because the surgeon is like the tailor, right? We need to customize your care, right?
So he's now cleaning the debris, the fibrotic tissue.
That's right.
Greater porosity.
There's a spur here, Alika. So I need to make this back. This is the spur.
Yes. Are you using a safer or a burr?
I use shaver because many times the lady is 65 like this, you have poor bone qualities. If you use the burr, sometimes you remove too much bone.
Too much,
and that can create the softening of the bone, and your suture can pull out.
Yes, that is the disaster for us because there's no fixation.
That's right.
Yeah. I think in my younger day, I did a study about the strongest place or the strongest location for anchor placement in the greater porosity. Do you have any preference? Let's say the lady is very fragile, the bone density is not good. I usually go to the just behind the bicep groove. What do you think about that?
Yeah, I totally agree. The bicep groove, I use that for my lateral roll. Yeah.
All right.
So I use that routinely for my lateral repair. I put in the bicipital groove. And another good bone is that the cortex, posterior cortex, close to the infraspinatus insertion. Yeah. And for my medial roll, I prefer to go to the cartilage bone junction.
Yes.
Okay.
Yes.
And very gentle. I will not remove too much bone. Okay. And then you remove the bursal tissues from the back. That is the infraspinatus.
Yeah.
And you see well?
Yeah. Can you see the assistant is holding the arm in that position so the surgeon can actually access the infraspinatus?
Yeah, that is the benefits of the bead chair.
Yes.
So the decubitus guy like Juhani, they traction. So I'm not good in lateral decubitus, sorry. So I think for the rotator cuff, be working and we can rotate the head, right? I'm more happy. But for instability, I prefer the decubitus or supine position. Yeah.
Position-wise, you can do lateral and bead chair position, but generally, a beach-chair position is more anatomic in doing rotator cuff surgery, especially for a beginner. So it's ease your orientation. You have to talk a little talk to your anesthesiologist just to make sure everything is okay.
Yeah, right.
Yeah.
But Elika, you train from in-hole John, right?
Yeah.
In-hole decubitors or he the beach chair?
He is a beach-chair position guy for rotator cuff surgery and lateral guy for instability surgery.
Okay.
So
Same like me.
yeah, same, yeah.
Yeah. Okay.
It doesn't matter. You can also do a beach-chair position for instability case. It's just your choice. If you can access the very low portal to the 6 o'clock, then let's go for it, right?
So now I'm going to the ankle switching stick.
Yes.
Okay. So first I will, so this is important. You need to be just in front of the AC joint. And this should be vertical like this, right?
All right.
For the beach chair is good because you can rotate. Even your portal is not accurate. You can rotate the arm, right? Like this. This is a good, you see, trajectory is okay. You happy?
Yes. So this is the consideration of the anchor placement. In the old textbook, they are saying everything about the dead man angle by Steve Barker. So these are maybe important for the one who would like to do a fellowship. Usually your professor mentioned about this.
Yeah.
So this is...
First I will do the marrow stimulation.
Yeah.
Yeah.
Bone marrow
small, right. Yeah.
So what is the size of the owl you used just now?
This one is about 2.5.
Right. So I believe that the size of the owl is important. If it's too big, it will cause the cortex to be collapsed, and
that's right.
Small is preferable because it leads the good adipose tissue containing bile component to be out.
Yeah, but I will not make it too close to my anchors. My anchors should be here, one of them. Can you go? Yeah, this is my anchor. Go.
Okay.
Yeah, one in the back. Yeah. One in the front and one in the back. So my front view, I do external rotation, and in the back, I do internal rotation. Can you go?
Do you always do crimson duvet in this all your cuff, or?
Yeah, always.
All right.
Yeah, because I think the stimulation, the cup healing is very important.
Biology consideration and mechanic consideration. So as you can see, they are tapping very slow because they are afraid that the bone might be collapsed. The distance between each hole should be considered as well.
Yeah, right. So one more here for stimulation. Go.
Stronger one. So you can see this viewing portal is the posterior superior. Now working portal is just beside the AC joint. Yeah.
Okay. So next step is to นี่มันเพเยอะมาก Okay. Okay. 5. Yeah. จับไว้นะ Hold that. Okay.
Is that a cannula from a meniscus? Yeah.
Yeah, that's right. That is a slot cannula.
Yeah.
It's from the meniscus set. Yeah. So it's very useful because sometimes we don't need. Yeah.
So as you can
the bone quality is not bad. Eliga.
The skin, we have a 4.5 hour for a helicoil insertion, if I'm not mistaken.
Yeah, right.
Is that the plan? Yes. Okay, helicoil is the anchor with venting system. So they have a hole in the anchor, so it promote healing. Okay, after you tap with the yellow one, you make a tap again with the silver one. And okay, it's interesting. I never used a cannula before, but I will try after this. Yeah. Okay, can you see there is a fan There's a, so the anchor is not solid.
Yeah, so this is helicoid. It's not solid. The good thing is that the bone ingrowth, bone ingrowth will be better. Yeah. Mallet.
Is this a double loaded or triple loaded anchor?
This is the triple loaded anchor.
Okay.
Yeah.
So we have a 4.5 and 5.5 millimeters inside.
That's right. Okay. A pipe. Okay. Good. Take out. Is that the hole? Yeah. Go.
Usually now the assistant is rotating the arm into
Internal rotate. Yes.
position to ease the surgeon work. So
Yeah.
you can see there is a laser line. You need to stop in the laser line and proceed with the next step.
Yeah. Right. Okay.
Looking very good, like a cooking show.
Yeah. Cooking show.
Cooking show, yeah.
Cooking.
Rotator cuff surgery is the queen of arthroscopic shoulder surgery today. Yeah.
Okay. Nice.
Okay, you can actually use a cannula to assist anchor insertion, but today he's using the meniscus cannula from the knee.
Yeah. Right. Because you can control better, Erica.
Yeah, correct, yeah. Because sometimes the cannula from the shoulder is flimsy, but the knee cannula is sturdy. Yeah.
Right.
Yeah. Okay.
Very good. Yeah. So now we are ready. Yeah.
So can you see the back is a double loaded one, the front is a triple loaded one.
Okay. So first thing is that our plan is, I think this patient is we need to do diagonal reduction this way, Erica. Okay. So I use my infraspinatus as a pose, right? Okay. So my first stage we go into the infraspinatus. Okay. Suture retriever. Action. So this first stage, this is double loaded. Okay. The stage piece. So we use this is Acropass.
Okay, can we have a outside view?
View please, outside view.
Acropass is a suture passer.
Yeah, right.
So it comes with a
this one.
Several
Yeah, this one. Yeah.
type.
So here, we use the infraspinatus as a pose. I will put one sutures into my infraspinatus.
Yes.
Okay. Hold this for me. Okay. Suture retriever. A loop. So this is a loop, right?
Usually this is the test for the fellow if he or she can manage a suture management. Yeah.
Ding, 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 ding. Suture retriever.
Yeah.
So I use the way we call hybrid repair. So this one we go 1 3 1 3 3 1 because I don't want to make too many knots. Okay.
So you can use not medially will be knotless.
We call the hybrid repair. Okay.
All right, hybrid.
Yeah. So hybrid repair. So first I will go this way. This is my reduction.
Yes.
Okay, hold this. Yeah, and coming from the front. Okay, here, check. I will reduce this and we go a little bit more medial. Yeah. Take out. So we pat this in, suture retriever. Yeah, you can see here this our suture retriever. And hold this, chạm đi. จับยังได้ยังได้ยังเรียบร้อยใส่ไปเลย2 นิ้ว
So there are several
So
ways
this
to
is
pass.
yes, Dalika.
While you're doing your work, I will describe to the audience. There are several ways to suture rotator cuff suturing. You can use a retrograde or antegrade. It really depends on how you would like to proceed. But doing the suturing of rotator cuff with Acropass, I think it's more like when you stitch your skin, so you know you move freely with your needle. So that is just my personal feeling, but you can use any device that actually you are comfort with.
Okay, so this part I will repair the tiger, this one, to the infraspinatus, right? And this blue, I will not make a knot, okay? So it's a hybrid. You can read my articles, we call the blended suture bridge repair, okay? So the next one, I will also go 3. This is 1, 3, and then 3, 2, 1, okay? So you have less strangulation. Yeah, so I prefer the blue one without knotless for my blue. Yeah, here's the one.
So I would like to.
Now that if you make too many knots,
yes,
you may have the type 2.
Yeah.
Type 2 tear. Okay.
Yes. So I would like to translate what Professor Bancha is doing now. He is preferring not to have many knots in the rotator cuff to perhaps reduce inflammation, to reduce knot cutting, and to actually it's like your ORI-IF when you have a limited contact plate to your bone. So you would like to condition the rotator cuff with no attrition from the knot.
Oh, yes, broken. So now here, okay, we hold this, yeah. The chip on. So this is 1, 3, and then 3, 2, 1. Okay, make it half. Lock it. Got it? Okay. Oh. Okay. Suture retriever. So from our study, we found that we have less type 2 tear in this repair technique. RF, please. And then I will share the anchors to my subscapularis. Yellow.
Yes. So he is repairing subscap from the subacromial joint, which is
right.
You can do inside the joint or outside the joint. It really depends on your situation.
Yes, right. So here is my supra, and then another 2, 1, I will go to my subscapularis. Okay, that's my interval. Yeah. Look at this. This is a subscapularis, right?
Yes.
Okay. Needle.
So it means he wants to use the anchor on the front for one pair to the subscap, and the other one he will use for supraspinatus.
Yeah. Okay, here, knife.
Okay.
So your portal should be lateral to the conjoint tendons, right?
Right. Yeah. So he make another portal just to work with the subscap
Yes, here, okay? So you see that this is a switching stick. You can work from here, okay? Dilator. Very good. At least she's very strong.
Oh yeah, she's the best. Yeah.
Yeah. Let's go. Go, go. Alista. Alista, show you're strong. Too small? Okay. Go. Deeper. Go, go, go. Yes, that's enough. Right. Go.
So this is a cannula. I think it's 8 millimeter in size. It's a green one. Okay.
Okay, here, this is your upper part of the subscapularis.
Yeah.
Okay, here I pass my suture into my subscapularis, like this. You can see from this view.
Nice puncture to the tendon. I think it's grabbed very good. Yeah.
Thank you. So now you can see from this view, like you're looking from in the box and outside the box, okay?
Yes.
One. Okay, let's go. Okay, we doing. Should do. Go, Alisa, very good.
Will you repair the subscap in what fashion? Simple or anything?
We make it mattress.
Mattress, okay.
Yes, and then we use the suture from the subscap to shelling the lateral, right? You see here? This is my subscap, okay? I think one more bite is enough for subscap because it's small tear, okay?
Yes.
Yeah. Here you see upper part subscap well. So my assistant will make a posterior push. Yeah, posterior push, very good. Here, don't include your conjoint tendon, okay? Every time when you repair subscap, you make sure that you are not including your conjoint tendons. Otherwise, the patient will not happy. Okay?
Bancha, can I ask you a question? It's really
Yes. Please.
Yeah, so I'm curious, are you going to do a biceps tenodesis in this case? So,
No, she's too old.
okay, so you're just going to do tenotomize?
Yes, right.
Okay, so another question also is, when do you use your biceps as a biological graft? So,
Use
how
bicep.
often do you do it?
So I use that for my bicep SCR, okay? If I have the big tear that we cannot cover the whole footprint, I will use biceps for my tissue augmentation. Yeah. So that is my biceps indication for tissue augmentation. How about you?
It's the same. So if I have quality issues, I will use the biceps to augment my
massive tear, right?
my bad condition rotator cuff. Especially in my country, wherein a lot of patients get steroid injections, get PRP injections. I'd also like to ask you, what's your experience in those patients who get those steroid shots? Do you also get problems with rotator cuff quality? So that's what.
Right. But we should have some gap after you do the steroid injections before doing the surgery. Okay, at least 3 months. Yeah, because I have the same problem here. We reduce the rotator cuff to the infraspinatus. Okay. Oh, this. Yeah, I agree. Yeah, I try. Yeah, some patients have poor tissue qualities. And also we worry about the infections after the steroid injection. So we have some time gap between the last shot of steroid, right, before the surgery. What do you think? You agree?
Yeah, I agree also because we seem to get a lot of those patients who get a steroid shot. So.
Okay. Okay, yeah, this is my first stitch. Okay, suture retriever.
Hi, Bancha.
Yes, Juhani.
Yeah, Johanny. Yeah, so
Juhani, that's not mean you are my honey. Someone thought that we are gay. Sorry. Because your name is Juhani, not honey. Okay?
Okay.
Yes.
I have a comment about the subscap repair. So
Yes.
probably as Erica talked before about the can be a debate, those kind of partial tears of subscap, whether we have to repair it or not.
Yes.
10 years ago, 20 years ago, I didn't repair it, just did right. But the problem is there's can be it not repaired subscap sometimes cause the retear of well-healed supra. 10 years back, 15 years later, the repair of supra is retear because of the failure of force coupling. So nowadays I'm a little bit aggressive to repair the subscap.
Oh, really?
Yeah, right. So I agree on this kind of repair with the subscap, even partial tear with under the 50%, 30%, it's better to repair it to make the force coupling anterior and superior side.
Yeah.
And also,
for you, you're a bit aggressive for subscap repair, right, Johanny?
Nowadays, yes. I have 10 patients of delayed repair of the supra. That's probably due to neglected subscap repair. So since several cases of the repair, I do a little bit more aggressive on subscap repair.
Yeah.
So as you mentioned about
even the patient have no subscap symptoms, right?
No symptoms, partial tear, probably it will restore.
Same like this patient. Yes.
And also you talk about the rotator interval, the preservation for my preservation. So routinely, if I cut the biceps tendon, even patient is old enough, I do tenodesis with subscap repair with rotator interval closure. So that will probably, we can some force coupling or force distribution anterior, superior, and posterior side. So that's one of my routine if I repair the subscap.
Thank you so much for your sharing, Johanny. Thank you. Okay. Suture retriever. So now we're leaving the blue. ไปฝั่งนู้นเลยก็ได้นะไปจับข้างบน Push, posterior push. So that is my shelling anchors. This is my last shelling. Push, posterior push. Yeah, very good. Okay, that is my stitch. Last stitch. This stitch is for the subscapularis repair. Okay, for this. Camera. So the post is important. I use the post here. So the post is the posterior suture. I use the posterior post. The anterior suture, I use the anterior post. So after you distribute this post, it will be uniformly distributed. Yeah. So it's important for you to distribute your sutures after surgery. There will be less dog ear deformity, and the cup will be uniformly distributed. Compression, okay? Suture retriever. Here I take one out. I think maybe we can have one free suture here. Excuse me. Yeah, here we can have one more free suture. Okay, suture retriever. Can give me a mini first. Free suture.
So he's now using a different type of suture passer.
Yeah, right.
I mentioned before, it can be retrograde or antegrade.
So traction, please, RF. So, Erika, I found that if you have the blue, yeah. You see that each hole we have 2 sutures, 1, 2, 3, and 4, okay? Here, this is 1. So you see the gap between the hole is uniformly distributed. 1, 2, 3, it's about 6 to 7 millimeters between the gap, right, blue? And you have less knot, okay? That's the point. And the gap between the holes should not be too close. From one study, we found that if you are closer than 5 millimeters, you can create the type 2 tear, okay?
Right, correct.
In the first piece. So this is the mini first pass, yeah, from Smith-Nephews. It's very user-friendly.
It will catch the suture cuff from under the surface and let the suture automatically deploy to the above surface, and you just need to take it out from the mini first pass.
Yes.
Yeah.
So here, so the posterior part.
Yeah.
Yeah. So this part. So using this way, your ankle will have less strangulation because you're sharing the load to the this free suture. They're sharing the load to your epic reduction. Okay. A pusher. We have some fat tissue traction this way. Or this. So I prefer to put the knot in the back, so the patient cannot feel the knot under the acromion.
Yes.
Okay, like this. You can use absorbable sutures also for this.
Yep.
Because the load is not too much. You just side to side.
Yeah.
You can use white krill, yeah.
If I may share about the non-absorbable suture, so
Yes.
I find it in the rabbit experiment, animal study that we did. The absorbable suture give us a lot of quite some inflammation process. So I'm afraid that it will lead to a re-tear as a big spot. Yeah, so I think your decision is better using the suture from the anchor suture. Yeah.
Yeah.
I think it's the way they do marginal convergence in the early day. Yeah.
Yes.
Yeah.
Okay. Then we cut the suture. This is a free suture.
Yes. Okay. As we can see now in the monitor, the footprint is almost closed, but he wants to put the lateral row to have a double row configuration.
Okay, now suture retriever.
Excuse me.
Yes, please.
So now we are going
we have
to...
a question from Dr. Arenaldi. Please go ahead.
Okay, let's go. Renaldi.
Good morning, Prof.
Hi. Renaldi is my beloved fellow also.
Prof,
But I would like both of them equally, Alisna and Renaldi.
Prof, I would like to ask you, Prof. You put in this kind of situation, the bladed sutures, you put the 1-3-3-1.
Yes.
Or probably more than that. You can make a sutures at the back and the front.
Yes.
Can you explain to us again about the distance? Because sometimes if we want to make a sutures and the hole is getting closer, so it can create the the distance is closer and the distribution is not really good, like because it's getting closer.
Yeah, right.
Thank you, Prof.
So Aldi, when you plan to repair, you mean when you tie the knot, the gap should be wider because once you tie the knot, I prefer 8 millimeters, the one that I plan to tie the knot. So once you tie the knot, the gap will be from 8 become 5, okay? But the one that you don't tie the knot, 5 millimeter is fine, okay? So like the one you see in the back, this one, my plan at the beginning is about 8 millimeters. So after you tie the knot, it's become from 8 to be 5, okay? So you need to plan beforehand. Otherwise, the gap between the suture will not equal. Yes. Because we want the uniform suture distribution. Hold like this. Okay.
Now the professor is...
Thank you, Prof.
Okay, thank you.
Is, checking for the lateral anchor location.
So we're going down. That is the GT, upper part of the GT. We're going down about 1 to 1.5 centimeters around here, close to the posterior cortex. This is my posterior cortex, right?
Yes.
Because this area, the bone quality is good.
Yeah. Can you show us the outside view? Can we see the
outside
hand position?
Go. Outside, you can see Alista doing the internal rotation. You can see that. Can you zoom out? Yeah. She's doing internal rotation because we will not go out.
Yes.
Stop. Yeah.
So usually in this lateral side of the greater tuberosity, the bone quality is...
Can you see the arm? Can you zoom out a little bit to see Alisna, the camera? Yeah, you see that? Yeah, here. The arm is internal. Yeah, here.
Can you zoom the camera?
Yeah, hold this. That camera. I think that camera.
We cannot see that, but I would like to translate it. So if you want...
Zoom out. This one, zoom out. This one.
Yeah. Front view, you have to externally rotate the arm. But if you want the back of the greater tuberosity to the posterior, you need to internal rotate the arm. Yeah. Yes. Thank you.
Yeah. See, internal rotation.
Yes.
Okay, the arm. Very good. Okay. Hold this, and then go back to the scope, right? Okay, hold this. Very good.
So this is the multifix, I think.
Multifix ultra.
Yeah, for the lateral anchor.
That's right.
How many stitches?
My beloved anchor. Yeah.
Yeah.
This one you can put 6 sutures, right?
Okay.
Now we put 5, right?
Okay.
Okay. So you're going here. You can feel the bone quality here is good.
Can you see the internal view?
Inside view, please.
Inside view, please.
Yeah.
The scope view.
Please. Thank you.
Okay, good. Yeah. And then you see the gap between the suture. It should be equal. If it's not, I will try to distribute. You see the blue one and the black one is too close right here. Okay. Yeah. So you should separate the suture first.
So now he's moving the suture because they are too close to each other.
That's right.
He wants to share the load and close
share the load to have the uniform suture distribution. Okay. So now it's better. Okay.
Okay.
And you see the gap between here and this one. This away. Okay. So tension. This one I going more in the front. Yeah. You see the gap between the sutures. Go. It should be equal. Yeah. So that means every square millimeters of the rotator cuff was compressed by the suture. That will have the good contact healing. Go. The blue.
This is a principle of a transosseous equivalent repair.
That's right. Okay. Hold this for me. Mallet, please.
So the good stuff is coming out.
Yeah. And then you tap again here.
Yeah. Usually I hold my breath when doing this. Yeah.
Here.
Right. So it's really important to know your implant, your stuff when you're doing your surgery, because not anchor are all the same. So you might want to talk to a representative about the feature of each anchor, how much suture it can hold for the lateral fixation. Yeah.
Okay.
So it looks perfect.
Yeah. But the suture cutter here is the old model. I'm sorry.
Yeah.
I need to cut it one by one.
Actually, you can scold the Smith and nephew assistant, he is also my assistant.
Yeah, this is the old one. Yeah, I'm sorry. We need to
No
go like
problem, no problem. Yeah.
You have enough time for me? Sorry. I spent some time for my suture cutting.
No problem. Yeah. Go ahead. So cannula-wise, do you advise to always use cannula or in rotator?
Yeah. For the ankles, I think it's better
really
to use
important.
cannula, right? But for the RF, please. But for the anterior, superior, you don't need. I think that, but the lateral one is, for me, is easier, blue. Otherwise, you may have some soft tissue.
In between.
Yeah, in between, right? Yeah.
Correct. Yeah.
And this step we call combing the hair, right?
Yeah.
Make,
It's like
make a good, handsome rotator cuff. Okay, yeah, that's one. You see the gap here is gone, right? Because we make the side to side or apex reduction, okay? Suture retriever.
May we know the intra-articular water pressure is still 30 at the?
Yeah, we are 30 all the time.
Yeah, this. May I comment to the audience? It's very skillful in subacromial joint. You only use 30 millimeter mercury pressure.
What's another one? This one, right?
Yeah.
Okay. So, Alega, the next one, as you say, we prefer to go close to the bicipital group, right? So we prefer to move the suture like this, right? So you have wider area of the distribution, okay? Should not go too close.
Yeah.
But the decubitus surgeon, they will have difficulty to do this because it's difficult for them to rotate, right?
Yes.
But for Bancha, it's easier for you to. At this point, you can see Alista, she's now external rotation.
Yeah.
Can you zoom out, see the arm, cameraman? Oh, this?
Very good teamwork. I think she really know what to do now.
Hello?
Yeah.
Okay. So here, yeah, you follow the tuberosity, okay, then here you can feel the bicipital groove, okay, after your external rotation, here, yeah, here, you see, that is the groove is here, okay?
Which is the greatest bone density, so you can sleep
That's
very
right.
well, yeah, after.
See well here, this is a bicipital groove, okay? So in the groove, the bone quality is good. Yeah, if you have osteoporosis, I recommend you to go into the groove. Yeah, because from Elika's study, she found that the bone in the groove is the best, okay? Here, yeah, we are now here, okay? And look east, yeah, that's nice. And also this groove is close to your subscapularis. So you can do like 2-in-1, double row supraspinatus, double row subscapularis.
Yeah.
Okay.
I think it's a very sensible in a financial way, I think.
Yeah, right. Because Indonesia and Thailand, we are similar.
Yeah.
Yeah, we have to save the money for our patient. Okay, let's go.
This is the golden owl.
Stop.
Tap.
Nice. Nimbawa.
You can see the assistant is very good. She or he is holding the cannula. Once the owl is going in, no change in position, hold your breath. And next it is the multifix.
Yeah. Yeah.
Almost done?
Almost done.
Almost done. So you can see the aperture of multifix alignment is very important.
Yeah, so you should go perpendicular.
Yeah. Okay. Good work, good work.
You see good bone, right?
Yes, very good. It's like when you tap your tibia by your interference screw.
I'm sorry, that
And
is
hear
my
the
bicep.
sound from the bone, yeah.
Okay, it's good. You hold this for me. Okay, now look at the suture configurations.
Yeah.
For this,
Check.
the front, yeah. I think this one is a bit too close.
Okay. He's rearranging again the suture to
Yes.
have the same distance to each other as the premise to share the load.
Okay. It's good.
Okay.
Okay, go. It's good, go.
Yeah.
Okay. Then one is good.
So it
Okay.
looks like your surgery, Dr. Renaldi. Same style, yeah.
Same style, right?
Yeah, same style, yeah.
Okay, go. Very nice. Okay, good. For this, my leg, please.
You can see the arm position is externally rotated because now they are in the front. Anterior.
For this. Okay. So bicep is in our way. Sorry about that.
No problem.
Okay, cutter. Maybe bicep was already tenodesis.
Should I say this is a financial gain as well? Yeah.
Yes. We check. Good.
So you have so many seat belt now? Yeah.
Yes, right. Okay. Blue. Blue. So today we also have the Minister of Health, yeah, coming to the hospital. Yeah, welcome the Minister of Health team, right?
Yeah.
So this is the very official live surgery. Yeah, thank you the Siloam Hospital for this organization. Yeah, ASSA-IOSSMA. Yeah, and also thank you the Smith Nephew for your support. Right? Okay. So now if you look at this, yeah, this is the distribution from the back. Yeah, this is the anchor in the back, blue. Okay, and also the anchors in the front. Looking at the subscapularis here. So we're looking in the interval. Yeah, the subscap is here. Yeah. Okay. So you look at this. Yeah. So we test the mobilities of the shoulder, right? It's not stiff. We can external rotation fully, right? Without tension. Yeah, internal rotation.
Yes.
Okay. Yeah.
Beautiful. Yeah. Beautiful.
Yeah. So any questions from the audience?
Yes, we have Dr. Nunes as a question.
Yes, please, Nunes.
Can you please kindly show us the inside view so the audience can see how perfectly it's reduced?
Okay, inside view.
In particular view.
Okay. Thank you.
Thank you.
I will go in the joint again. Yeah, switching stick, please. Let me check.
So everybody looks good and still alive. Nice job. Yeah.
Yeah. Still alive, yeah. Nunes. I tried. Nunes is a bit swollen. Okay, I think I'm in.
So the purpose of looking from inside view is to check whether the rotator cuff has been reduced properly to the greater tuberosity, and actually maybe judging from the repair construct just now, it should be a very perfect view of the inside one.
So that is your subscapularis. You see that?
Can we see the inside? Yes, please. Thank you. Wow.
It was reduced now, this infraspinatus, and that was the supraspinatus attachment, right, to the tuberosity. Okay, the subscap, supraspinatus, the articular side.
Can we have an applause for the repair, please? There's applause from the floor for you. So very beautifully, perfectly done. Thank you for the team.
Thank you, Elika, and thank you all the team. Alisna, Sexton, Stan. Thank you.
Any further comment from the floor? You are welcome to give questions. If the biceps is incorporated to the repair, any consideration for the rehab, Prof? No?
No problem. We actually, we did not concerned about the bicep, right?
Right. So we have a question or comment from the floor. Please go ahead.
Please. Switching stick.
Dr. Bancha, I'm Eric from Jakarta.
Hi, Eric.
Hi, Prof. Very
How you
nice
doing?
surgery. Great job. Professor, I'm just wondering, when you put the lateral anchor, douglas anchor in the bicipital groove, when you're not taking out the biceps, how do you know if the long head biceps is sutured by any means?
Yes. Thank you, Eric. That's a good question. If you still have biceps in the groove, I mean, if you do not cut the bicep is still there. You must be very careful. Don't repair your biceps with your rotator cuff. Otherwise, the patient will have so much pain. Okay? So make sure that you not include your bicep. Every time when you pack the sutures, if you still have bicep there, you need to make sure that your bicep is not included into your rotator cuff repair. Okay? But this patient, we already resect the bicep. That's not the problem. Okay? Eric? Answer your question?
Yes,
Satisfied?
Prof.
Okay.
Thank you.
Actually, we can try, Dr. Eric, because we work as a partner in surgery.
Oh, you work together, Eric and Eric. Okay. Thank you so much.
All right. Thank you so much for the support from the Smith and Nephew, and thank you, team. You have a great day ahead. I think you should still have one surgery to go, if I'm not mistaken.
Okay, Elika, take one picture together with us.
Oh, okay. Wait.
You too.
1, 2, 3. 1, 2, 3. Thank you for everybody who is watching the live surgery of Professor Bancha's team. Have a great day, everybody. Bye.
Have a good day.
All right, today we conclude a very nice double row repair from Professor Bancha Chernchujit, who is also supported by the Smith and Nephew for the surgery today. So now we are coming to the next session, which is, we actually skip the tea break. Now we can actually start the tea break. Thank you, everybody.